Hi, I'm Deb Kimmett, and I'm the Executive Director of the LMT Body Politic. And the LMT Body Politic is a massage therapy policy think tank. We delve into policy areas that affect massage therapy profession, and tonight's topic does just that. Some of you may be wondering, well, how can a 514-word document generate about 45 minutes worth of content? Well, part of it is that I want to set the context and what the science is that is part of our consideration regarding the critical analysis. Before I begin, tonight's talk is a presentation on a paper that I've written, and the PDF will be in the notes. If you're not interested in listening to the full 45 minutes or reading the full paper, one of the things that I recommend is reading the introduction and then skipping to the very end where there's a bulleted point of items that are at issue with the Great Barrington Declaration so that you can get a quick view. But tonight we're taking that deep dive look into it because I think that it's important to set the context and to fully understand what it is that's going around. There's a lot of quotes here, and I may not always attribute them as quotes by putting in the quote words, but when you do read my document, they are quoted and sourced in the document itself. And I've also tried to clearly mark them on the slides as well. So let's begin. On the surface, the Great Barrington Declaration looks like a viable plan for addressing the COVID-19 pandemic. Its supporters are gaining traction based on the support of the current administration, and also they're gaining traction because of COVID fatigue and the public's desire to want to return to some sort of pre-COVID normalcy. But after careful analysis, the Great Barrington Declaration, which I'm going to abbreviate and call the GBD in this document, but after careful analysis of the GBD, it does not conform to any of the prevailing science, and it ignores what we currently know and don't know about the novel coronavirus. And further, it is incomplete and doesn't advocate for a clear, comprehensive public health policy approach to the pandemic as well. The GBD's architects acknowledge the reality that public health initiatives can be politicized, but they appear to be at best naive, or at worst dismissive toward the political fallout of this particular policy. It's precisely because of this short-sighted view that the GBD should be and has been characterized as a highly partisan political policy based on pseudoscience. On one end of the political spectrum, the supporters favor a small government solution that prioritizes personal freedoms and financial cost-cutting, while the opponents are basically appalled at the cost in human lives that such policy entails. Physicians take an oath to do no harm, and research scientists sign off on ethical standards. The Great Barrington Declaration violates both. So no, it's not a viable plan. But what is it? What is the Great Barrington Declaration? Well, first of all, 3 infectious disease epidemiologists and public health scientists met in early October of 2020 to sign and promote a short policy position paper named after the locale in Massachusetts where they gathered. They dubbed it the Great Barrington Declaration. The paper is a broad-brushed approach to the COVID-19 pandemic called focused protection. The architects of the GBD assert that a new approach is needed because, and I quote, "Current lockdown policies are producing devastating effects on short and long-term public health," unquote. These effects range from fewer cancer screenings and declines in mental health to lower childhood vaccination rates. Now, their premise is to protect the elderly and the vulnerable as they are at higher risk of death from COVID-19. And what that also means, though, too, is that schools, restaurants, businesses, and bars should reopen so that the young and the healthy who are at lower risk can go about their business and, quote, build up immunity to the virus through natural infection, unquote. In short, the GBD outlines a modified version of herd immunity, and we'll come back to that in a moment. So let's talk about who's criticizing this paper. Well, research revealed many articles that outlined opposition to it. As an aside, I used somewhere over 20 in putting together this critique. And so those articles are either quoted or written by epidemiologists, infectious disease specialists, and other scientists. And after looking for articles supporting the idea, only one article was found that supported it. The supporters article was written by two statisticians and a mathematician who seemed to base their opinion on discredited science. Experts have come forward to repudiate the GBD from a wide range of organizations and groups. The Infectious Diseases Society of America and HIV Medicine Association denounced the GBD as it did not include data or evidence, and the GBD states that this crisis can be controlled in the absence of critical public health measures. The World Health Organization Director General is clear that the intent of herd immunity is not to intentionally expose people to a virus. And he said that never in the history of public health has herd immunity been used as a strategy for responding to an outbreak, let alone a pandemic. It's scientifically and ethically problematic. And other public health experts have weighed in. One group wrote the John Snow Memorandum, which is published in The Lancet. And as of October 15th, 2020, over 600 top-tier scientists, virologists, and the like have signed on to it and have added their names to the memo. These experts warn that the GBD is nothing more than a distraction that undermines development of an effective response to the pandemic. And 20 public health organizations have condemned the GBD as a plan that would haphazardly and unnecessarily sacrifice lives, and that the plan itself is not based in science. So let's explore why all these scientists and groups are upset with this plan. So let's talk about herd immunity. And yes, as an aside, it did have its origin in livestock management. The term has many meanings, but the implication is that when enough of a population becomes immune to disease, the number of infections decrease, and the risk of infections for those who lack immunity is also decreased because immune individuals surround them. This immunity typically occurs either through vaccination or through contracting the disease, recovering, then becoming immune. And once the level of herd immunity is reached, an epidemic typically ends as there are far fewer people to be infected and the disease can be controlled. In theory, this idea sounds good, but in reality, herd immunity without a vaccine can be difficult, if not impossible, to reach. We know that scientists have determined that 60 to 75% of the population needs to be immune to halt transmission of COVID-19. It's based on what's called the herd threshold theorem that refers to how much of the population needs to be immune to stop disease transmission. And it's disease specific, and COVID-19's is 60 to 75%. But we're not sure the accuracy of this number. It could actually be higher. So as far as where we are now, the presence of antibodies in a population is an indicator of possible immunity. And yet after months, let me say that again, after months of exposure to the virus, the presence of antibodies in studies done in cities in Spain and Switzerland in June and July was less than 10%. And as of October 21st, the number in the United States is about 2.5%. This number was taken from taking 8.3 million reported cases dividing by 330 million total US population. But the number of unreported cases may drive that number higher. In fact, one author puts it at fewer than around 15%. And even then, we simply don't know whether the presence of antibodies can lead to herd immunity. And this is important, so let me say it again. We don't know whether the presence of antibodies can lead to herd immunity. Those low numbers in Spain and Switzerland led commentators in The Lancet to state that any proposed approach to achieving herd immunity through natural infection is not only highly unethical, but also unachievable. You may also be hearing that to achieve herd immunity only requires 50%. This isn't correct. This is the vaccine effectiveness rate required for vaccine approval by the US Food and Drug Administration and the World Health Organization. This rate is below the Thurman threshold of 60 to 75%, which means that social distancing, wearing masks, and other precautions must remain in place. One public health official says that a vaccine of over 80% efficiency would be needed to discontinue these other types of precautions, though. But a vaccine alone doesn't work either. Because the spread of a virus is heterogeneous, meaning that it spreads unevenly and not uniformly through a population, there are pockets of outbreaks and infections. And one former director of the Centers for Disease Control, the CDC, who helped develop the approach that eradicated smallpox, he likened it to fighting forest fires. Clear away the immediate fuel around a fire to help put that fire out. Thus, the best means of controlling the virus is to surround pockets of infection by vaccinating those nearby. And it may also mean isolating pockets of the infected so as not to infect those around them. However, extending this concept to mean that you could lower the theorem threshold is a misconception, as the numbers are theoretical and may not apply to the real world. And finally, as a way to gather support for the idea of herd immunity, some politicians have pointed out or pointed to New York as an example of reaching herd immunity. But both Virginia Pitzer, an epidemiologist at the Yale School of Public Health, and Anthony Fauci, director of the National Institute of Allergy and Infectious Diseases, are clear that the claim is false. So that means it's unlikely that we can get herd immunity via natural infection, and to try would be unethical. But even though this research debunks the GBD's attempt at herd immunity, the authors persist. They're making assumptions that simply are not true. And the first one is stating that herd immunity can be assisted by, but is not dependent upon, a vaccine. As I've already mentioned, the experts have determined that this is simply not true. Herd immunity in the case of SARS-CoV-2 is not possible without a vaccine. However, it does make sense that the GBD's authors would believe this, because Sunitra Gupta, one of the primary authors, has insisted that herd immunity can be reached when 10 to 20% of the population has been infected, far below that theorem threshold of 60 to 75%. So while Gupta's numbers help us understand why the GBD's authors believe that they can reach herd immunity without a vaccine, and as I've already noted, most epidemiologists disagree with this, saying that the percentage is much higher. But there's more. We don't know if immunity lasts. One article points out that as of October 16th, at least 4 studies showed that antibodies, which indicate immunity, don't last. And in the latest one in that study, cited by Kavanaugh, 58% of the subjects tested negative at 60 days. This indicates that immunity may be short-lasting, but we still don't know for sure. What do we know for COVID-19? Quote, there is no evidence for lasting immunity following natural infection, unquote. And yet, one video posted on the GBD website, Gupta sidestepped the question of how long immunity lasts. And in another, she appears to be guessing when she says, quote, if it's like the other coronaviruses, that would be 5, 10 years, unquote. If the authors do not appear to understand this basic issue, how can they be confident that their focused protection plan only needs to be 3 months in duration to be successful? This is a major issue. Tied to immunity is the problem of reinfection. One statistical modeling study points out, quote, if immunity is not perfect and there is a moderate to high chance of reinfection, then prospects for achieving herd immunity via natural infection are slim, unquote. What that means is that if people can be reinfected, they aren't immune for long, and the question of herd immunity is off the table. And here's what the research says about reinfection. There may have been a few cases of reinfection, about 24 as of October 6th. It doesn't seem like much, but the only way to tell if somebody has been reinfected is to do a genome study, and not everybody gets a genome study, which means that then the experts believe that there are a whole lot of cases that have been missed. And there are questions concerning immunity and reinfection. For example, how long before somebody gets reinfected? In one case, immunity lasted less than 2 months. The subject tested positive the first time in mid-April and then was reinfected in early June of 2020. We also don't know if the symptoms of reinfection will be more or less severe than the original infection. There's evidence supporting both scenarios. The potential for a more severe case is deeply concerning when intentionally exposing a population to the virus. These questions of immunity and reinfection pose ethical challenges under any type of herd immunity plan. If it were clear that immunity is long-lasting and the chances of reinfection were low, that might mitigate the risk, but we don't conclusively know. And to act on assumptions that have not been proven is at best risky. Without clear answers, implementing a herd immunity plan will put lives at risk. Another big question raised by the GBD is who is vulnerable and deserves protection under the focused protection plan. The authors primarily use age as the delimiting factor, claiming that death from COVID-19 is more than 1,000-fold higher in the old and infirm than in the young. The authors don't cite a source for this claim. We don't know if isolation factors are accounted for in this 1,000-fold figure. For example, with schools shut down and families isolated, the young may not have had as much potential for exposure as an elderly person living in a nursing home or assisted living facility that had workers coming and going. So we just don't know. Nor do they define what they mean by young or old and infirm. We don't know if the old and infirm describes one population or two, or if it only includes those in nursing homes or assisted living facilities where rates of infection have skyrocketed. The GBD also claims to protect those with highest risk without defining who's included in that population. The CDC uses terms like increased risk or at risk for severe COVID-19, along with higher risk groups. There doesn't appear to be a highest risk group. And what we do know is that while the GBD plan fails to clarify exactly who is vulnerable and who should be protected, the GBD overemphasizes mortality rates, those at highest risk of death. Other vulnerable populations appear to be completely ignored, those with comorbidities and those who survive COVID-19 but with long-term effects. But let's talk about these for a moment because it does speak to the feasibility of their plan. So let's start with comorbidities. One study estimates that over 45% of the US population has one or more comorbidities, conditions that put the person in danger of death should they contract the virus. What's more remarkable is that this study excluded residents of nursing homes and assisted living homes. Excluding these populations gives a clearer picture of those who would likely be asked to go back to work under the GBD. While the study has not been peer-reviewed as yet, it was funded by a grant from the CDC. It seems unfeasible to provide focused protection to 45% of the population, in addition to those in nursing homes and assisted living facilities. Just as a note, another study did put the number much lower, but it didn't include risk factors like obesity. Also not taken into consideration by the GBD is that while some comorbidities are diagnosed prior to contracting the coronavirus, others may go undiagnosed. If the young and the so-called healthy are encouraged to live their lives, exposing themselves to the virus, this means that those who have undiagnosed comorbidities are in danger. This presents yet another ethical conundrum. Is it acceptable to expose the unwitting vulnerable to the virus? So comorbidities must be taken into consideration when estimating the death toll of a herd immunity plan. Experts have estimated the death toll from trying to reach herd immunity, if we could even get there, to range from 500,000 to 6 million dead. Those numbers should give anyone pause. We also have to dispel one very big assumption of the GBD, that the young will very easily get over the virus. Not all do. In one study, more than 1/3 of COVID-19 patients still had symptoms. They still felt sick or, quote, in a worse clinical condition, unquote, 60 days after diagnosis. The long COVID effects were most prevalent in those aged 40 to 60, and other experts estimate that the number of long haulers at 10%. And further, Kavanaugh contends that while younger patients are less likely to have symptoms, they could be beset with problems later in life as, quote, pulmonary and cardiac reserves decrease, unquote. He's probably referring to the lung and heart damage caused by COVID-19 and the strong possibility that as we age, those problems will become more evident. Again, what are the ethics of exposing 10 to 30% of the population expected to work or go to school to long-term and possibly lifelong effects? And what kind of drain will this put on our healthcare system? Another problem with the GBD is it's impossible to isolate the vulnerable. In the paper I wrote, I have 3 quotes on this issue, but I think this one really says it all. It explains why it's impossible to isolate the vulnerable. What starts in young adults doesn't stay in young adults. First come cases in young adults, then the virus spreads to older adults and medically vulnerable people. An interviewer with the GBD's authors asked how they would handle a situation where a child and a grandparent lived in the same home. The answer was incomplete and not clear. The interviewer was only told that separation is done for a short period of time. Such a separation plan is not feasible in multi-generational, lower income households. This is just one example of how the plan is very thin on details and not well thought out. Here's another problem. The GBD asserts that one way to protect the vulnerable is that nursing homes should use staff with acquired immunity and perform frequent PCR testing of other staff and all visitors. We've already discussed the immunity issue. A person could be reinfected. And since a person with acquired immunity is assumed to be immune, according to the GBD, they would not be regularly tested. This person could be an asymptomatic carrier and infect those under their care. And yes, the facility could test everyone, but there are some other concerns about testing, okay? In those who do manifest symptoms, testing is less accurate before symptoms show up. Scientists just don't know when an infectious person will start testing positive, making a testing scheme unreliable. Also, an individual can become infectious a day or even hours after the test, which also renders the testing scheme unreliable. And the best time to test is 5 to 8 days after exposure or 3 days after symptom onset to get a true positive with an RT-PCR test. But this also isn't helpful because waiting until a person shows symptom is too late. A person can be contagious 48 to 72 hours before symptoms appear. And in the case of an asymptomatic carrier, they'd be contagious before testing positive. Again, this puts a wrench in the testing scheme proposed. In short, protecting the vulnerable is nearly impossible because of these testing problems. There's another problem not mentioned in the GBD: overwhelmed hospitals. A study that statistically modeled the spread of SARS-CoV-2 found that herd immunity is not workable, as hospitals would be overwhelmed, and this model assumed long-lasting immunity, which is not what we know about COVID-19 immunity right now. So based on simple math regarding the infection rates necessary to reach the lower threshold of herd immunity of 60%, and the World Health Organization's figure that approximately 1 in 5 who've been infected require hospitalization, we can estimate that about 39.6 million people will need to be hospitalized. And here's where it gets scary. There are under 1 million total beds available, and about 1/10 of those are ICU beds. Granted, not all who are sick will be hospitalized at the same time, but this points out that if there's a big spike in infections, local hospitals can be quickly overwhelmed. Here's the impact. Not only would the system be overwhelmed with providing care to those infected, the influx of COVID-19 patients would severely impact the healthcare system's ability to provide healthcare to the uninfected, like car accidents, heart attacks, elective surgeries, and so on. And this directly undermines one key rationale of the GBD, that the healthcare needs of non-COVID patients are being neglected and would be addressed with implementation of the GBD. Instead, it would make it worse. Experts also say that the GBD endangers frontline workers. Not only does the plan put hospitals and their personnel in the direct line of infection, those who work in various essential services are also put at risk of infection. These include bus drivers, grocery workers, building materials workers, and others. The GBD seems to make several assumptions that are based on false choices or false premises. Many of those are implied from what I've already said, but let's take a look at some of the others. Lockdowns versus focused protection. The GBD's authors assume that scientists want extensive lockdowns until a vaccine becomes available. Well, that's just not the case. Full lockdowns are only for times of high transmission and while figuring out how best to handle outbreaks. Other critics point out that there are proven strategies that work that go beyond this either or choice. In fact, South Korea and New Zealand, which were very successful in defeating the virus, didn't use either strategy. Another area is an improved or harmed mental and physical health and the economy. The GBD's authors are right to say that mental health and physical health of Americans can deteriorate during a lockdown. But under this plan, however, there's still a lockdown for the vulnerable and the elderly. And as outlined before, this will be a significant part of the population. Evidently, it's acceptable to the GBD's authors to sacrifice the mental and physical well-being of up to 45% of the population, in addition to those living in nursing homes and assisted living facilities. Critics also point out that these negative effects, including socioeconomic impacts, have been worse in places that did not take advantage of the lockdown to put in place effective systems to control the pandemic. The United States is a case in point, which I'll address later. And then I have an other category, for lack of a better term. Here's what GBD co-author Gupta says in response to a challenge by an interviewer who stated that schools haven't been allocated the resources that they need in order to reopen safely. To set a better context with what's on the slide, here's the whole quote. Quote, well, they don't really need, and then there's a garbled word. It doesn't matter if they're infected. I mean, so I was going to say this, a couple of issues. One is proportion. Okay, I'm 55 years old and obviously there's a slight risk, I guess, but why wouldn't we accept that risk to teach students? That's our job, to take on certain risks to perform our duties and our responsibilities, unquote. To her benefit, she then goes on to say that older teachers should be able to teach virtually. Gupta assumes that it should be the duty of younger teachers who may have an undiagnosed comorbidity to put themselves in harm's way. Is this callousness? Is it naive? Or is it cavalier to believe that some should sacrifice themselves for the greater good? No one should be put in that position. The GBD has been compared to Sweden's pandemic policy. The GBD's authors suggest that the only flaw in Sweden's model, as opposed to the GBD, is that Sweden failed to protect the elderly. However, they concluded that based on the antibody state that it has worked. Co-author Martin Kulldorff explains that the old in Sweden had half the number of antibodies compared to those of working age. And from that, he concluded that herd immunity worked. Well, this conclusion is false. You cannot conclude that antibody distribution levels in a population indicate that herd immunity has worked. Remember, I said earlier that the presence of antibodies may or may not indicate immunity, but without further data, you can't conclude that this successfully led to herd immunity. In fact, we have an indication that herd immunity hasn't worked at all. Sweden is slowly backing away from their current model and adopting what other countries have done. As of October 14th, 2020, the death toll in Sweden is more than 20 times that of other Nordic countries. And officials are noting that the, quote, level of immunity in Sweden's cities was not as high as the health officials had recently believed, unquote. In short, this experiment in herd immunity failed. This undermines any support for the premise that reaching herd immunity is possible, which is, again, a major premise of the GBD. And that brings us to what's missing from the GBD. Besides the problems outlined above, experts complain that the GBD ignores the fact that the US has not actually taken the steps necessary to control the pandemic, and that these steps are a necessary part of any plan. The first step is to reduce the spread and then box the virus in, and that's a way to stop cases. The US hasn't done a good job of this. The US hasn't used strategies used successfully in other countries. For example, the widespread testing, contact tracing, and universal mask wearing. Plus, there's been a lack of ongoing support to provide, quote, financial and social programs that encourage community responses and address any inequalities that have been amplified by the pandemic, unquote. For example, 8 million people have fallen into poverty since May when the CARES Act money ran out, with no aid package in sight. Another strategy that has not been widely used is to employ rapid testing to quickly isolate the infected and their close contacts, as well as to institute strategic closures. Also, not enough personal protective equipment has been widely distributed, and little funding has been supplied so that schools can reopen safely. Instead, what's happened is that mask wearing has become politicized, and critics charge that the Barrington authors have embraced a false dichotomy that lets our public health system, the government, off the hook. Controlling the pandemic isn't a choice between lockdowns and letting the virus rage to achieve herd immunity, unquote. And this leads us into the next section regarding politics. Critics have been clear that, and I quote, "The declaration is not a strategy. It is a political statement. It ignores sound public health expertise. It preys on a frustrated populace. Instead of selling false hope that will predictably backfire, we must focus on how to manage this pandemic in a safe, responsible, and equitable way," unquote. The GBD is a policy statement, and governmental policy is political by its very nature. While all decision-making around whether the GBD is a viable solution should be based on the science, it's important to explore the political impact of the report and the politics behind it. The GBD's authors discredit the idea that politics is behind the plan, and yet the sponsor of the initiative is a political think tank. The New York Times reports that the GBD grew out of a meeting hosted by the American Institute for Economic Research, AIER, a libertarian-leaning research organization. In keeping with their libertarian roots, the AIER website touts that we're an advocate for personal freedom, free markets, private property, limited government, and sound money. It appears, though, that political ideas from the sponsor bleeds into the GBD. At the end of one of the videos is this tagline. This speaks volumes. No economists are listed as co-authors of the document, yet the GBD is being touted as being an economic strategy too. It appears that they're being given equal billing. The co-authors seem to understand that the GBD will be politicized, but they don't seem to take any responsibility for the political ramifications of the paper. For example, co-author Jay Bhattacharya says that after he released his data that, quote, "I don't have a lot of control what happens after that," unquote. And later says, scientists can inform the debate about what should happen, but fundamentally the trade-offs involved are political trade-offs. And co-author Gupta is unconcerned that the GBD is sponsored by the AIER, as she says, the idea behind the GBD is outside of politics, and co-author Kuldorf agrees. But more on this in a moment. Mask wearing is one issue where political viewpoints can come forward, and the prevailing evidence is that Wearing a mask helps contain the spread of COVID-19. But Bhattacharya disagrees, calling the evidence uncertain, and that you don't need to wear a mask unless you're actively coughing. Again, this viewpoint is contrary to the prevailing science. Gupta and Kuldorf do wear a mask to the supermarket, but in the context of the GBD, Gupta doesn't view refusal to wear a mask as libertarianism or being about freedom. In this case, it's a very communitarian approach, meaning that not wearing a mask would lead to infection and the building of community immunity. In her view, this is good for the community. Again, they seem to discount the political aspect of what's going on here. It's not libertarianism, it's communitarianism. But what is the role of public health in the political sphere? I put in all the details in the companion paper with references, but the short version is this. Scientists who propose public health policy have the responsibility and obligation to understand the political ramifications of their proposals and how such proposals can be manipulated for political ends. Their proposals should include a detailed implementation scheme to ensure that the author's intentions are clear and to bring clarity to the implementation process. So from there, if politicians do something differently with the plan, it's very clear that the author's intentions are being ignored. And if we were to speculate, there are only a few reasons why the authors of the GBD would show such a lack of concern to the details and to politics. They're either short-sighted, politically naive, or at worst, the authors are intentionally using this lack of concern as a smokescreen for a political, not scientific agenda. And given that the GBD sponsor is a politically oriented organization and the proposal has no basis in what we know about the virus, it's difficult to not jump to the latter conclusion. The GBD's authors have proposed a very thin policy proposal with absolutely no details. The entire document is only 514 words long with no addendums or accompanying documents. The GBD does talk about implementing policy proposals to carry out the declaration, but have done nothing concrete on this front. There are no calls for adequate funding. There are no details to determine exactly who's vulnerable, and there are no details as to how those who will be sequestered away from society will be supported financially, mentally, and emotionally. This lack of detail is ripe for political exploitation. And in fact, an anonymous senior official in the Trump administration told reporters that the plan is endorsing what the president's policy has been for months. And this is where the perversion for political ends occurs. Politicians get cover for claiming to implement the idea, but without any of the economic, social, and general support that the authors suggest is needed. But given that there was little attention paid to the support in the document, it makes sense that the politicians would do the same thing. It's in line with the economic philosophy of the GBD sponsoring organization and the current administration. Again, 8 million people have fallen into poverty since the CARES Act funding dried up, and the death toll continues to rise, particularly among those elderly and vulnerable that the GBD is meant to protect. And the administration can claim that they're doing something. They're implementing the GBD. In short, instead of crafting a well thought out policy position based on science, the authors have developed what is now a highly politicized policy based on pseudoscience. Further, critics fear that it could lead to even more Americans ignoring safety guidelines. Americans will use that GBD and the administration's agreement with a policy as an excuse not to wear a mask or not to adhere to physical distancing guidelines, touting their communitarianism. And given the highly politicized nature of the pandemic, Americans will become even further divided as the pandemic rages on. And the common sense strategies successfully employed in other countries to suppress the virus will continue to be ignored and unfunded. So that's just about it. These are all the problems that I covered tonight. and I'm sure that others have more. What I'd like to do is close the formal presentation with the words of Anthony Fauci. Anybody who knows anything about epidemiology will tell you that the GBD is nonsense and very dangerous because you will have killed a lot of people that would have been avoidable. In short, the Great Barrington Declaration is dangerous and may lead to the deaths of millions. It does not follow prevailing science and is not good policy. Physicians take an oath to do no harm, and research scientists sign off on ethical standards. The Great Barrington Declaration violates both. And so that ends the formal presentation. As a personal note, I did try to be as unbiased as possible. I took it from a science-based perspective. But what I came across made it very difficult not to have some bias because the science is overwhelmingly against the idea. I actually left out some of the egregious attacks as I thought that would detract from the information. But when I read about the authors insisting that the policy, the paper, the proposal should be debated and not be shut down, I realized something, that this debate really parallels the climate change debate, and even right down to the political aspect of it. On one side of the climate change debate, you have 99 out of 100 scientists who've concluded, based on the science, that climate change is real and is human caused. And then on the other, you have one who wants to be put on equal footing with the other 99. With the climate debate, for a long time, the media and those against doing anything about it would do a both-siderism kind of thing, where they would put both on an equal footing, even though one side was a fringe idea and not supported. And that gave the fringe a megaphone to convince a lot of people. This time around, at least the both-siderism is a lot less, but the proponents of the idea do have a megaphone in the administration. But the press is doing a better job this time. While they bring up the idea and talk about it, they really are giving the headlines and a voice to the critics that it's a fringe idea and that it's dangerous and that it won't work. And just again to comment that if indeed that this has been a policy that's been adopted by the administration and is administration policy, it really is a dismal failure, as we all know from our experience of dealing with all this. And there you have it. So I just really appreciate your time to take this journey with me on this deep dive into the Great Barrington Declaration, and thanks for watching.